Hi everyone, welcome. We'll start in a couple of minutes, just letting everyone come in. All right, let's get started, shall we? Hi everyone, and welcome to SANE's Mental Health Recovery webinar series. This is webinar number 3. My name is Jackie, and I am a service lead here at SANE, and it is my pleasure to shortly introduce you to tonight's guest, Dr. Rahul Khanna, who will lead our discussion on navigating trauma and bridging the gap between lived experience and clinical insight. So first, we would love to do an acknowledgement of country. So we'd like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional custodians of the country where we live, work and meet. We recognise and celebrate the diversity of Indigenous people and their enduring cultures and connections to the lands and waters of Australia. I'm coming to you tonight from Wurundjeri Land in Melbourne, and specifically acknowledge these peoples. Feel free to put the name of the country you are in or on in the chat. SANE has lived experience at the core of everything it does, and it's founded on lived experience. So at the beginning of every meeting and group and webinar, we intentionally recognise lived experience. SANE respects and champions the individual and collective expertise of people with a lived experience of mental health issues and their families, communities, and people impacted by suicide. We recognise their vital contribution at all levels and value the courage of those who share this unique perspective for the purpose of learning and growing together to achieve better outcomes for all. So we're going to start with some session housekeeping. For those who are new to using Zoom, there are a few features that can help you get involved in the discussion tonight. You'll find these options at the bottom of your screen, whether you're using a laptop, desktop, mobile phone, iPad, etc. First, there's the chat function, where you can post any comments as the discussion moves forward. When typing your comments, be sure to check where it's being posted. You can either send a comment to just the SANE team, so that'll be Rahul, myself, and our moderators, or if you'd like, you can also send a message to everyone. Make sure to change that if you do want to just send something to us. If you have questions for Rahul during the presentation, please use the Q&A function. This helps keep all the questions together, and we will do our best to get through as many as we can tonight. So use the chat for making general comments and for chatting with other participants, and use the Q&A if you'd like to send us a question. If you don't feel like making a comment but want to react to something in the presentation or give a round of applause, you can use the reactions to send one of the emojis that will appear for everyone. Exactly, thank you. Good work, guys. Glad to see the text working. Finally, if you would like to enable live captioning for the presentation, you'll find that function down here as well. Just some guidelines for tonight. Safety is very important to us, both your safety and everyone else's. We want to hear about your experiences, but please refrain from posting explicit details about self-harm, suicide methods, abuse, substance use, and medication names and dosages. We won't be providing any specific medication advice tonight. If you need immediate help, please contact the numbers on the screen. Please step out if you need to. This session is being recorded, so you can always catch up later. Privacy is also crucial when making comments. Please remain anonymous and do not share any details that could identify you or ask others to share that kind of information. Some examples are on the screen, such as full name, workplace, address, phone number, email address, etc. Finally, please be respectful in your comments towards our team and each other. We will have some moderators in the chat tonight who will keep an eye on things. We may need to remove comments that breach any of these guidelines. So, our speaker tonight is Dr. Rahul Khanna. He is a practicing psychiatrist, researcher, and educator who leads Transforming Trauma Victoria alongside lived experience co-director Charles Chu. This statewide trauma service is being established as part of Victoria's mental health reforms by Phoenix Australia in partnership with SANE and others. Across multiple contexts, from hospitals and universities to startups, Rahul works to translate the science into usable insights for trauma survivors and those that care for them. He looks forward to continuing that work through the SANE community forums. So, without further ado, welcome, Rahul.
Hi everyone, thank you for joining me and the rest of the team and for the warm welcome. Always feel just a touch awkward with all these introductions. But look, before I kick off, just some disclosures. As Jackie said, I'm a psychiatrist. I work alongside Charles Chu on Transforming Trauma Victoria. Alongside Phoenix. I also have a clinical hat at the Austin, where I mostly work with trauma survivors and also support More Good Days and SANE in a volunteer capacity. More Good Days is a chronic pain startup. Yeah, look, as flagged today, I kind of wanted to share kind of some of the sorry, actually, I might just hide the chat for the moment because it is a touch distracting as I talk, but I will return to comments afterwards, and I've got my timer running to make sure we save some time for questions. But today I'll be talking about trauma, how us kind of in the clinical space often think and talk about it, and really aim to try and kind of bridge the way the professionals have tended to kind of think about trauma and trauma-related illnesses and challenges alongside kind of the lived experience of those experiences. So let's just launch straight into it. So I guess let me move aside a little bit and try this jacket off. So I guess there've been a few definitions that have been done the rounds around trying to kind of define trauma, and obviously as it's become something that's been much more in the public conscience, things have changed in terms of how people view and think about and talk about trauma. But this has been one of the more inclusive of the definitions, which really looks at, it comes out of the US and really thinks about an event, a series of events, or a set of circumstances that are experienced as physically, emotionally harmful or life-threatening, with lasting adverse effects on functioning. And the things that I kind of like about this definition is that it also kind of focuses on the experience of the trauma itself. There's been a lot of angles on this that do focus a lot on trying to define very specific types of events or experiences as being traumatic or not. And in my work in the space over the last, quite a few years, what's traumatic to one person at one given point of time is extremely kind of unique and individual. And so it's really hard to kind of draw kind of strict lines or boundaries on these experiences. So I do find that this kind of strikes a nice balance in all of that, and also the breadth of things that that can be impacted. And And so some people have tried to kind of divide this up into, what they call simple trauma, type 1 trauma, single events that are sudden, unexpected, acutely threatening. And these are often kind of assaults or kind of car accidents or those types of things. And drawn a distinction between that and more complex trauma, to trauma that's been protracted, where escape's been difficult, sometimes occurring during childhood and that sort of thing. With the thinking that that type of trauma leads to and has more complicated impacts on people's experiences, and their development and are experienced in a different way. And the research kind of bears that out as well. Which also begs the question around this, around adverse events as well. And I'll talk a bit about sort of trauma, PTSD, and specific kind of diagnoses as well shortly. But I guess there's a few kind of broader themes around sort of people's post-traumatic experiences, and it's often around a breakdown in our sense of safety, our ability to trust and connect with other people, and really our understanding of ourselves and the world. It often, a lot of people grow up with this kind of sense or a reinforcement through TV and whatnot, and what we call the just world belief, that good things happen to good people, bad things happen to bad people. And fundamentally, the experience of trauma really challenges that kind of simplified belief system that we've got, and that obviously has these big flow-on effects, and so that can shape that, but also kind of our own sense of self-belief, our sense of being able to control the world around us, is often kind of impacted, and sometimes negatively. But that's not necessarily fate, and in fact, a lot of the types of challenges that we talk about in post-traumatic stress disorder, which I'll talk about later, are really, really common after a particular event occurs. So this one is this is a study looking at a whole bunch of research around experiences of individual assault and sexual assault in particular. And really what you kind of see is almost everyone's got symptoms and difficulties, about 80% or so, sometimes even higher, in that kind of first month or so after an event. But for a lot of people, that will naturally kind of just decrease over time. But it's the group that we tend to deal with in the kind of clinical world, and many of you who might be here as well, where somehow and for a range of reasons that kind of natural recovery has gotten stuck somewhere along the path. And we see sort of similar patterns with, whoops, I'm missing a slide, but anyway, we see similar patterns with other types of trauma. Though there is also a distinction around that some of that kind of early childhood or type 2 kind of experiences that we saw, which really does kind of increase the challenges people face on a whole bunch of fronts. And we'll loop back to that as well. Oh, here's that slide. So this is similar around natural disasters. So this was some studies looking at earthquakes, and the commonness of some challenges in that initial months, but then things tending to settle down for people in the long term. It'd be remiss of me also not to kind of talk a bit about post-traumatic growth as well, because there are sometimes, and after some experiences, and even sometimes happening at the same time, there can be both sort of that negative experiences, but also a lot of people who experience that a level of kind of growth, a level of kind of resilience that kind of emerges out of these difficult or challenging experiences. Particularly as whether by themselves or whether with support, they've been able to kind of overall overcome that experience. it can leave a lasting kind of strength as well. And really the aim of a lot of kind of care, treatment, support, and sort of recovery journeys really is to kind of move from that position of um, those negatives that we talked about through to a kind of a knowledge that even though we can't undo the past, we can kind of move beyond it. I was getting a drink with a friend, and given the experiences or the work that I currently do in trauma, she raised some of her own experiences in the decades gone by, and was reflecting that as much as some experiences still haunt her, that it's also meant that any challenge she now faces, she knows that she's been through much worse, and gotten through it, and so it's kind of given her this ability to kind of uh, pause, reflect, and go, actually, whatever X or Y is, or whatever this conflict that I'm stuck in is, it's at least it's not what she's already kind of pushed past. But I guess one of the challenges with it, and this is one of the reasons that I wanted to come along and speak today, is also the nature of kind of diagnoses in the first place. I think there's rightly a push against like an overly medical way of thinking around trauma and PTSD, and all of these conditions. And I wanted to kind of share a perspective around it, and also talk through how some of these things emerge, what they're used for by professions, what aspects of these concepts might be useful for you as someone who might have a lived experience, or be caring for someone who does. And I often think about diagnoses, or the idea of diagnoses, as quite similar to movie genres. The our lived experience of trauma, of life, of recovery, post-trauma, are a bit like, obviously infinitely more complex, but a bit like the movie. And genres or diagnoses are attempts by the movie buffs, by the critics, to kind of step back and try and kind of crudely group movies or experiences into neat boxes that can allow for people to communicate, study, research, understand, and help treat. And just like any genre is not going to give you all the detail about how much you will or won't enjoy or understand a movie, it's similar with diagnoses. They capture some of the experience, but also miss out on a lot. So I suppose the stance I often kind of encourage people to take is to use them for what they're good for in terms of guidance, but not also to take them too much to heart either. So some of those genres that we think about in terms of trauma are, I guess the most classic is chronic PTSD and PTSD and complex PTSD. But it's not it's not the most common, or not, and certainly not the only kind of diagnosis associated with trauma. In fact, it triples the risk of any mental health diagnosis. So depression, substance use issues, personality disorders, dissociative identity disorder, attachment trauma, range of other kind of ways in which people have sliced the experience of those adverse impacts from trauma, each of which have been studied in different ways with certain kind of therapeutic approaches that have been shown to be helpful in each of those. But they're just some of the flavors. Now, underlying PTSD and complex PTSD, not necessarily because it's the most important, it's just what I'll dive into a bit more today. So it might seem a bit counterintuitive to first put down the importance of diagnoses and then launch straight into talking about one of them. But I have found that going through it can still be um, quite helpful in some ways, because a lot of people I've worked with have said sometimes that, as I've kind of just gone through some of those ways in which we think about PTSD and the diagnoses, have said, oh, look, I thought you were reading my file rather than kind of, out of a book. So it clearly does, some of it does resonate with people. So in terms of the DSM diagnosis, which is one of the two main manuals that, or movie category kind of handbooks that mental health clinicians use, and the DSM-5 coming out of America is probably the more common one used in Australia. And so it talks about trauma in a more narrow way around being exposed to death, threatened death, actual or threatened injury, actual violence, either directly witnessing, learning it happened, or indirectly exposed to details through work, as a narrower definition. I think the reason I wanted to share this definition, though, is that obviously it is narrower than what we talked about earlier. And it gets back to kind of the background on how these diagnoses kind of get created as well, because as much as there's some science behind it, there's also a bit of kind of social context and politics. In the American world, they don't have a health system like ours, so unless you have a particular box that you can fit into, people aren't able to access any treatment and therapy. And there's also like a really big kind of insurance sort of footprint. So they have to, I guess, draw boundaries a bit more tightly than I think always, that sometimes makes sense. And there's also a lot of gray areas sometimes in this kind of diagnosis system. Severe bullying and those types of experiences are often things where, people's experiences around symptoms and challenges can be very similar, but on a technicality, sometimes it's, people struggle to kind of be diagnosed into a neat box. And that can be really invalidating for people. So, I think it's that old, if it smells like a bird, looks like a bird, you probably need to kind of treat it like a bird, and it doesn't matter a whole heap about whether you tick the box or not. But it's just kind of worth thinking about and knowing that that's sometimes, at the back of clinicians' minds when you're talking to them. But in terms of kind of what sorts of challenges or symptoms or things that come up in that kind of manual for clinicians to think about when they're thinking about PTSD, it's that experience itself. Then it's this kind of category of things called re-experiencing, so nightmares or flashbacks, or feeling in your body like whatever your experience was is happening again. So with your heart racing and all of that, whenever there's a reminder. And that's one of the more one of the most sort of common or prominent kind of experiences that people have when they've got PTSD. But there's also a few others, and so that tends to drive people to try very hard to avoid any reminders, whether that be internal, their own thoughts, or external, like places that remind you of challenging areas. And starting to kind of really have changes in how you might think about yourself, about other people, or the world itself, and getting kind of sometimes some views around how much you can or can't trust the world around you because of the impacts you've had. It can be really difficult to connect with others as well, or some challenges in feeling the more positive sides of life. And then there's another bucket of kind of challenges around our alertness system. So, being a bit more quick to anger, being a bit more reckless, this thing called hypervigilance, so feeling like you need to kind of be alert or on guard a lot of the time. People talk about needing to sit in certain places in a room so that they can see the exits and all of that type of stuff. Struggling with sleep and concentration as well. So it's a range of things, and not everyone gets all of these. And in fact, someone did the maths and said there's over 600,000 different types of combinations that people can have and still tick the box for DSM-5 PTSD. But those are some of the themes that come up. And then there's this the other big manual to confuse things more, the ICD-11, also talks about complex PTSD. And I thought it was worth kind of just touching on this one as well, because again, part of what I'd hope to do today, and we can respond to some of the discussion as they come up from here and maybe in the forums as well, is that there is also a bit of confusion around this kind of term gets used in a range of different ways, and because it's in one book and not the other, which is actually comparatively unusual for the area, it can cause a bit of confusion. So there's it's basically those PTSD type symptoms that I talked about, and it's also these three other buckets that they've very helpfully and clunkily called disorders of self-organization. So it's trouble with managing your own emotions, having a real kind of negative idea of yourself that's a bit more pervasive, and trouble in relationships. And then there's often this other kind of diagnosis that gets thrown around borderline personality disorder, and they all kind of link in with each other. I guess these are some of the ways in which people have tried to kind of distinguish between these. But really, in the end, a lot of it is around what makes sense from your own experiences, and how it might guide the therapeutic care that you that you find resonates with you and helps with the groups of challenges that you might face. But in a very sort of brief and rough and ready kind of way, some of the ways that it might be a bit different is that if people who've tended to kind of fall into that borderline personality disorder kind of narrative have real challenges sometimes with feeling that they might be about to get abandoned, or having some of those kind of urges around self-harm and suicidality, and impulsivity. So I guess so hopefully that gives you a bit of a sense on what might be going on in the back of the mind for clinicians that you see. But really, I think that's probably sufficient, and obviously, please, I'll dive into the comments around any questions, but hopefully that gives you a bit of a sense. But for the rest of the presentation, I really wanted to talk about treatment, therapeutic approaches, and just kind of more general tips, I guess, from my experience. So I guess in a nutshell, the couple of things that we'll talk about, firstly, are just kind of supporting ourselves and each other, trying to be trauma informed, and essentially that really relates to firstly being aware that trauma impacts a whole heap of people in a range of ways, and there are some things that are really difficult as a result, and things that can be triggering or challenging for people, and being a bit more sensitive to that in our kind of everyday interactions can be really helpful. A tip around, and I'll talk a little bit around kind of what the more evidence-based or research-backed treatment approaches are, so that you can more effectively or hopefully kind of know what might be helpful to ask for, and really around the fact that there are a whole range of options out there. And so even if something hasn't resonated or clicked with you yet, being able to kind of give a range of those a go over time is still worth doing. So I guess in terms of what we think works best. Firstly, we tend to discourage sort of just routine debrief. There was a time when that was seen as a really important and critical thing to do, but we know that immediately after a trauma now that probably doesn't help a whole heap. It can be helpful to kind of come together and have a space to share, but it's more the kind of notion of forcing people to talk about a difficult thing that's happened is not necessarily a good idea. And as we saw earlier with the kind of natural recovery concept, there are a bunch of people who actually, and in fact, the majority who might not have a whole necessarily a negative experience after that or long-term thing. But it is really helpful to have what we call psychological first aid around watching for and being aware that some people might get stuck along the journey and may need support. And trying to have stick as much as you can to a normal routine, avoiding things that might help in the short term, like alcohol or other sort of more problematic coping things, whilst trying to lean in on some of the things that might be a bit more helpful, that you have leaned on in the past, whether it be humor, but connecting with others. If things have been, if it's the type of trauma that has been with you from a very early time, sometimes building up just some skills around mindfulness or anger management or those sort of things can be really helpful, communicating more effectively, all of that. But there are a range of psychotherapies that have been really have their runs on the board in being super helpful. So but there is a bit of a caveat. I mean, I heard someone say, language is a dialect with an army and a navy. And so evidence-based psychotherapies are a bit like that as well. These are the ones that have had the really large scale clinical trials or research studies, and have won the kind of significant investment required to kind of have those studies, but also to have this kind of volume of people trained in doing them. So it doesn't mean that other things don't work and aren't going to be helpful. And I certainly have worked with a lot of people who found all sorts of things really helpful, from equine therapy and companion animals through to just I guess like there's a lot of ways really that paths that people have found to move beyond trauma. But it's often most useful to start with what has been well researched. And so with that in mind, these are the kind of set of things that have been found to be the most helpful. So this is a group of therapy approaches called trauma-focused therapy. So there's and these are all kind of different brands of that similar themed approach. Prolonged exposure, cognitive processing therapy, EMDR, trauma-focused cognitive therapy, and trauma-focused cognitive behavioral therapy. And they all have, the main shared theme is that they do encourage people to engage directly with memories of their trauma in a kind of really supported and gentle way and progressive way. Prolonged exposure is probably the oldest and most well studied, and I often refer to it as the chemo for PTSD, because it involves really talking about the trauma as if it's happening again, but in a supported environment, and using various breathing techniques and things to kind of push through it. you then kind of listen to recordings around it. It's quite a kind of intensive immersion around both what happened, but also pushing past some of the avoidance. The cognitive processing therapy has much less of an element around the memory itself, but it talks a lot more about the ways in which your thinking process might have shifted after the after an experience. So some of those like negative expectations that we talked about earlier. Um, EMDR is similar, can have a few of those themes, but instead of talking out loud about it, you do a lot of the thinking in your own head, and eye movements and others things are other types of stimulation and distraction help make that a more kind of doable experience. So there are, and there's others as well. There's a video, it's more kind of clinician directed, but there's a shorter video we'll be posting up in the not too distant future that goes through each of these in greater detail. So we'll try and put a reference to that up after this as well. Um, but those are the ones that have really been shown to be the most beneficial. So this is scores of therapy sessions that a colleague of mine did with an individual person. So PCL5 is a kind of rating scale that we commonly use for around PTSD symptoms that maps onto some of those things that we talked about earlier. And so this is that person's ratings week by week through the 14 weeks that they had the sessions. As you can see, you know, it's makes can make a really big impact, even though it is quite challenging to do that type of work. Medications also get used a little bit, but they do have a much smaller effect size. So there's no kind of PTSD specific medications, but there are a range of medications that have been used for other challenges that have been found to, you know, subsequently also be helpful for PTSD. So a few of the antidepressants, there's a couple of blood pressure medications, particularly prazosin, that have been studied a bit, and topiramate, which is also an anti-epileptic medication, and a few antipsychotics, also risperidone and quetiapine have been used as well. But there are a bunch of others as well. So Phoenix Australia do put together the Australian guidelines around PTSD and its treatment. So you can have a squiz at those on our website as well around you know, the range of things that have been supported by the research evidence, and you can kind of use that to with some of the practitioners that you are working with as well. But I suppose a few things worth noting. There's a few ingredients, obviously, that help determine where things go and how much you benefit from these approaches. And the therapy certainly does one part. But the therapist also matters, and I know that it's not always possible to find a choice, but often the fit between, you know, the person that you're working with and yourself, the way the therapist that kind of thinks, and the models that they're used to, you know, they kind of need to be ones that resonate with you as well. And so the impact of, you know, one therapy style versus another can be just as significant as, you know, one therapist versus another. So it is often worth trying one or two, or if you've not had a great experience with one person, to give it another go with someone else is often useful. Um, and you know, and trying to change as much as possible your environment as well, or other or those around you can also be a really helpful piece. I think, you know, the need and usefulness of sort of connecting with others, of finding some meaning and purpose, all of those other bits of life can be really helpful as well. And really, I guess the in my experience in the years I've worked in trauma, it is really hard to predict what parts of the jigsaw when and what parts of the jigsaw will come together for a person in along their journey. And so, we've certainly my reflection often is that sometimes it's um or to a large part, it's often just around persistence and time. That certain things that you think will work sometimes don't. Other things that you are unsure about, you just find people really run with and it resonates. Sometimes it's a book, sometimes it's someone they met, sometimes it's a whole bunch of random and chance encounters can really make a big impact. So sticking it out is sometimes half the battle. Um, there's a bunch of resources also obviously available online to follow up. Phoenix Australia has a range as well, as does Sane. And Google is your friend. And obviously, in response to the chat, I can put some other things. A quick plug also, we're about to launch a clinical trial around lavender extract for PTSD, novel kind of approach. This will be the world's first large clinical trial in the space. So I think that QR is not active today, but it will be in the next couple of days. So keep an eye out for that if you're interested. But my rough ramble is over. Happy now to just take some questions and go from there.
Thank you, Rahul. We've had so many questions. It is almost impossible to keep up with them all. Just a reminder that to put your questions in the Q&A function and not in the chat. They will get absolutely lost if they are in the chat, given how many beautiful questions we've got coming through. I don't know if we'll be able to answer all of them, but I will try my best to group them together as well. Let's start with the very simple one, which is the first one. Does everyone have trauma?
Yeah, so traumatic experiences, like the ones that tick that, even the narrower definition that I talked about, probably about 70, they reckon between 60 and 75% of Australians will face that at some point in their life. So yeah, quite a few.
Quite a few, but not 100%, obviously.
That's right.
Yeah. So someone is interested in the definition between complex PTSD and just standard PTSD.
Yeah, so um, it's been a confusing journey because people have used the term in different ways. So there's some people that, particularly until the ICD kind of included it as its own thing, some people used to just use it as to refer to any PTSD that was severe, and wasn't going away as it's supposed to when you do like X or Y or treatment. Others had been advocating that borderline personality disorder is just too stigmatizing a label and it should all just be called complex PTSD. Um, and and that's still a way that a lot of people use and think about the term. But the kind of ICD version, that big manual that had its particular take on it, has a much more specific kind of definition, and that's those three added bits that I talked about, and I can flick across to. So it's still, I think, a contentious issue, and not one that everyone's resolved yet. So Jackie.
No, and there's lots of contentious questions I will note
Okay.
in here. Again, we are not trying to avoid any of these questions, but just given the time frame, trying to group a bunch of them together. An interesting one here. How do we define intergenerational trauma? An example being First Nations communities.
Yeah, absolutely. So look, we certainly think about it as the traumatic experiences that are kind of passed through generations, and I think that it's through two different kind of mechanisms. We know that some aspects of kind of negative experiences kind of flow on in a very biological kind of way in terms of um, the impact of various kind of hormones and things, while people are kind of pregnant or, in that early years. There's that kind of that level of um, kind of impact that it has, but it's also the secondary kind of experience of, growing up with someone who might have had some of those challenges that we've talked about in terms of sort of PTSD symptoms, that in itself can be problematic. For people, if your parent has had difficulties with anger or what have you, then that can create an environment that's in itself feels less safe and therefore, has that kind of flow on effect as well. So there's a range of ways that it can be impactful.
For sure. I've seen a few questions around dissociative identity disorder, around the recognition of that. Is there any kind of change in how the systems are kind of classifying and viewing that at the moment?
Yeah, look, I think there are, and there's a level of kind of both, yeah, as I said, there's the science and then there's also like the politics and social stuff, a lot of diagnoses have their own kind of rise and fall in terms of popularity as well, or public consciousness. So, in the case of DID, there was some periods of interest around some books and more public kind of consciousness around it. But I think often, I take a reasonably agnostic approach to these things. I think a lot of people's experience is their experience, and as long as it's often useful to have a frame that helps kind of make sense of your experience and allows you to kind of talk about it. But none of those diagnoses are going to fully capture, I guess, people's
Mhm.
experience.
Yeah, and I guess you spoke about that earlier around like the benefits and the way we look at diagnosis versus experience as
Yeah,
well. Yeah, for sure. We have a few people asking generally just advice on like interventions and treatment, and can trauma or be treated, particularly if it occurs when people are quite young but they haven't received any interventions for decades. Any
yeah,
thoughts on that?
yeah, absolutely. So I mean, I often uh think of well, firstly, I've definitely worked with people who've had PTSD for decades and found they've made significant improvement because they've finally, found a combination of sort of treatment or approaches that work. Um, and that can be a really hard thing because sometimes for some people, that what they found worked for them actually was in the end quite simple, and then they feel like, oh, I've gone this particular person always kind of is burnt into my mind. Someone I looked after about a year ago, um, who I didn't do a whole heap for, to be honest. He was admitted under me, and then I went on leave. I came back at a meeting, and at that meeting, I heard that he'd had, this particular kind of therapeutic approach tried, and he'd, been going great guns. Um, but when I saw him, he was, really devastated. And I said, "Well, look, it sounds like you were doing really well. What happened?" And he's like, "Yeah, doc, I am." But I've just been thinking, I've been like this for 28 years, and these are all the impacts it's had. If someone had told me do this thing, it'll be really shit, but you'll feel a lot better later. Back then, how different my life could have been. And so he was, obviously mourning that kind of missed thing, but it wasn't not quite so simple because we obviously didn't have those treatments necessarily, or we didn't have the confidence that they'd work back then. But they certainly can. And I know I'm going way over time, but also with I think that's the flip side as well to the borderline personality disorder kind of label as well. I think it became so negative and stigmatized because there was an assumption that it couldn't change. Whereas now we know that yes, it's they're not overnight fixes, but in months and over the span of a year or two, you can get really significant improvement. So yeah, so absolutely 100% treatable.
Yeah, we've got lots of people mentioning different types of interventions and therapies. So some people have mentioned sensory-based therapies, transcranial magnet-based therapy. DBT is one that comes up quite a lot, and has a lot of evidence as being quite effective in that space as well. Some mention of some medications, which we said we wouldn't really touch too much on tonight, but from my understanding, medications don't typically treat the cause.
Yeah, so I guess the way we think about medications is really to try and help get people to be able to benefit from the therapy. So it's just trying to help give enough stability for that to happen. Um, the hard my main tip around medications though will be that it's often worth it's sometimes worth keeping a diary or using Googling some of those kind of rating scales around depression and PTSD. I made mention of um, the PCL-5 in one of my slides, but there's a bunch of these validated instruments that you can use, and which will help you keep track of whether medication's helped or not. Because it can just become so hard to go, oh, did I feel a little bit better, 3 months ago? Maybe I did, or maybe I didn't. And we find that if we do measure these, and it's rough and ready, but it can really help make sure that you're getting benefit from whatever you're on.
Yeah, for sure. Um, yeah, definitely some questions relating to the system and the challenges within the system for people with experiences of trauma, such as within the NDIS, the public mental health space, the private mental health space. It's a very contested kind of very challenging area to navigate for people who are already often quite disenfranchised. Um, just looking through
Yeah,
some more because we have a lot of questions. I'm trying to pick out some that we haven't kind of touched on
sure.
at
Yeah.
all.
Look, yeah, just in terms of the system, look, we are trying our very best around with the statewide trauma service in Victoria to try and kind of be an example on how that might be done. But as we talked about, the sheer number of people that do have that experience of trauma means that we kind of have to think differently in how we approach improving care and experiences around trauma more broadly. It's not just a case of kind of we don't want to create a system where you need to have special people do special things in some special corner. We're trying to kind of have a system where everyone is kind of trauma competent. And a lot of these therapies that I talk about, um, they're not rocket science to actually implement. They're confronting insofar as they're challenging to kind of work through. And so it makes both therapists and others kind of squeamish around it, and so you do need some confidence to do it, but they're not that hard in and of themselves.
Mhm, for sure. We have someone who said, what is trauma-informed practice? What I'm getting at is that those persons with disabilities struggle with government and can be traumatized from the process, e.g. NDIS, and the government not wanting to help with trauma-informed practices. I think that is a challenge across all of the systems at the
Yeah,
moment.
yeah, definitely. I think the other challenge with a lot of this stuff is that sometimes you need sufficient like time and resources that people can kind of implement that properly. Because a lot of the basics are giving people, yeah, all of these things take time and can't be rushed.
Mhm. A few people wanted to know about the types of trackers that you mentioned before. We've got
Oh,
a few people who want that recommendation.
So there's a few rating scales that we use commonly. I'll just put down a couple in the hang on, I should put that on everyone, right? So these are three common ones that get used. The PCL-5 is the PTSD checklist. That lines up with the DSM-5 kind of criteria. There's sort of 20 questions about people's experiences scored out of 80. The ITQ, the International Trauma Questionnaire, is the like ICD version of that. It's got a couple of questions around PTSD, a couple around complex PTSD. And the PHQ-9 is a depression questionnaire. But there's basic, online calculators that you can find in each of these. So if you type in PCL-5 and calculator, you'll find one. But yeah, you don't want to over-engineer it, but every now and then kind of filling it out, once a month or so while you're doing it just can be useful. Yeah.
For sure. Okay, I think I might pick one more question. Can mental illness diagnoses overshadow trauma and create further harm?
Uh, yes, and what? Yes.
The tricky one, yeah.
Look, I think there's a big challenge around what we call diagnostic overshadowing, where someone will so say someone has been diagnosed with psychosis or schizophrenia. Very often clinicians will stop thinking about other things, and there's a very strong overlap with sort of PTSD and other post-traumatic kind of issues with everything. And sometimes treatments can be the same or similar. Like yes, there was a study, and it hasn't. It's probably unsurprising that things that are hidden are also not often studied. So there aren't many studies that have done this, but a team in Adelaide went to an acute psych unit, and they just interviewed basically everyone who was there, doing a structured sort of clinical interview, and they found about 34% of people could have been diagnosed with PTSD, but only sort of 2% had that somewhere on their file. So this was a few years ago. Hopefully it's a bit better now, but still, it was just the fact that, it hadn't been picked up for so many people. So yeah, so that overshadowing kind of concept is frequently a problem, and I think that can do harm. And I think the other thing is one that happens, and again, when you're not tracking whether someone's actually benefiting, particularly around sort of antidepressants and things. Sometimes people just end up on stuff for a lot longer than they need to be.
Yeah, which you see a lot in the intellectual disability space in particular as well. That's a very tricky
Yeah.
area to work in. It's close to my heart as well. Well, we've pretty much come to the end now. I just wanted to bring everyone's attention to a link that I've just popped in the chat. It is to, I guess, an evaluation of how you felt tonight went, and it gives you a space to give feedback. We will look at that, and that will help us make better webinars, improve our practice, and gives us suggestions for further webinars coming up. We do them monthly now, so keep your eyes peeled for the next one coming up next month. But I just wanted to thank you, Rahul, for coming tonight, for speaking to us about the relationship between the lived experience and the clinical nature of trauma, and talking about the challenges as well as some of the nice, exciting stuff that's coming out of your work and the work of other people as well.
No problem. Thanks, everyone. Have a
All
great
right,
night.
thank you, everyone. We appreciate your attendance. If you would like to click on that link, it will disappear once you leave the meeting or once I close the meeting. So click on it now. But thank you so much for your attendance, and we look forward to seeing you in the next one. Thank you. Bye.